So I said, Ahmad, one of the urologists in University Malaya. Unfortunately, my CV not as extensive as Dr. Dila, so that's why it's quite short. But anyway, so just going to talk about, as I said, the focus on this thing is prostate cancer screening and its management. So I'm just going to bring about a case. Okay, so I'm from UMMC, and also we work with the Urology Cancer Trust Fund. Okay, so as I said, just want to make this a bit more interactive because so I hope anyone here can just try. I'm sure most of you are familiar with menti.com. Okay, so we start with Mr. X. So Mr. X is a 66-year-old man, no lower urinary tract symptoms, no family history of prostate cancer. So this is basically a screening patient. So he comes to you and asks you about, prostate cancer screening. Okay, no particular reason. Past medical history, nothing really that significant. Bowel palsy, gout, and as a part of a routine assessment that you do a examination, physical examination, the DRE, which was unremarkable. Okay. So he asked if at this point he should do any tests. Okay, and he mentioned that he read about the PSA test. Okay, so what would you do now? Okay, do you think there's a lot of news about MRI. There's some people say do PSA straight, and they want to do the latest thing like PSMA, or some people say he's 66, he got no family history. Shall we just wait and see, and wait only if things change, develop any symptoms, I need to do something. So in the interest of time, I'm gonna go. So I think now when I talk about screening, I think shared decision making SDM is in thing nowadays. I think this applies to breast cancer, cervical cancer, lung cancer screening, colorectal cancer. All is about shared decision making. I think nobody can really say 100% that you must do something. Okay. So currently, as for now, there's no rule about MRI or PET PSMA for primary screening in the asymptomatic patient. Okay, because screening we know we talk about asymptomatic patient. So of course we need some evidence to back us up. Okay, so Cochrane, the last one was in 2014. And of course, as you know, due to lead and lifetime bias, when you do screening, you are going to increase the diagnosis of prostate cancer. What they found is that it tend to increase diagnosis of the early stage cancer, and they didn't found any cancer specific or overall survival benefit. Okay. More longer studies, okay, the PLCO study, quite important for us urologists, okay. Mean follow-up 16.7 years, it found no survival benefit, but it found increase in indolent cancers. Indolent cancers means Gleason 3+3 or the new ISCP1, because they tend to be less likely to progress or metastasize. Okay, and the other a big study is the ERSPC study, and found that in 16-year-old that you need to treat quite a lot, okay, to prevent one cancer death, okay, and in order to prevent one cancer death, also you need to diagnose 18, but this means that the number that you are subjecting to unnecessary screening and unnecessary diagnostic tests is actually quite high. Okay, so that is the problem with screening about anxiety and over treatment and over diagnosis. Okay, so what is current practice? So most of countries use opportunistic or so now they use a key term SDM. Okay, even in US last time, actually in 2013, they actually recommended completely against PSA screening, but this led to an increase in prostate cancer diagnosis and mortality. So actually in 2018, they revised it, and they said that again, shared decision making for those 55 to 69 years old. How about Malaysia? So far, our last thing was in 2010. It showed that population screening, as in most countries, is not cost effective. And so what do? Actually, we tend to actually do a more risk-adapted strategy. So actually, this is from the European Association of Urology guidelines, which is what most urologists in Malaysia do. Okay, so to cut short, you normally screening you should do with patient with a good life expectancy lah. Okay, so if somebody is frail, bedbound, then there's no point talking about PSA screening. Okay, but if they're well, then you can offer after again discussion with the patient for men above 50 years of age, And then for those who have family history of prostate cancer, particularly first or second degree relative, certain relative with certain cancer mutation, breast cancer, pancreatic cancer, then you may want to test them earlier. And then you can also adapt how often you're going to test it based on their risk stratification now. Okay, so as you mentioned, the key thing nowadays for your for screening is shared decision making. Okay, so after you had your discussion with Mr. X, so you order a PSA result, and the PSA come back as 7.86. Okay, so not super high, but it is above the normal cutoff that Malaysia takes as 4 lah. Okay, so what would you do now? It's fine. Okay, so I think that's what most people say. Most people would repeat the biopsy, okay? Because the PSA is not super high, okay? And sometimes PSA can be raised to other things, prostatitis, UTI, or not. So actually, in the EU guidelines, actually recommend if it's 3 to 10 and there's no mass on there, you can repeat the test. How soon should you repeat the test? About 4 to 8 weeks. Okay, so you repeat the test a bit longer, unfortunately, but come back as a 9.6. Okay, so nowadays, when you talk to patient, there's a lot of tools you can use online. So this is one tool that you can use, and it's actually you can actually access it easily online. The QR code there is for those interested. So you can see this is actually based on the ERCP, ERSPC, sorry. So they actually created this online risk calculator that is quite easy to use. So based on this PSA, it actually gives a chance of finding prostate cancer with further study about 41%. Now, of course, bear in mind this is based on European patients' data, and there are some slight differences between European and Asian patients. Okay, so what will you do next? Okay, would you want to do a MRI, or would you go straight for PET scan? See whether anything lights up suggestive of prostate cancer, or would you repeat the PSA, or would you go straight for biopsy? Would you go for transperineal biopsy? So I think it's good to see that nobody actually said for biopsy. Okay, so I think so of course nowadays with latest study, particularly they have a few important randomized control trials, the precision study, MRI first, and the 4M study, all suggested that when if you do MRI before prostate biopsy, increase the detection of clinically significant prostate cancer, ICP2 and above. Okay, so that's why now ideally we do MRI in all patients. And what do you get for MRI? It's very similar to breast. Okay, so you have a PIRAT score. Okay, so you can actually grade. So basically, we are concerned for PIRAT score 3 and above. Okay, very similar to breast cancer as well. Okay, but the problem is that PIRATS has been around for years. Whilst PIRATS is still something new, and although they have come up with newer versions, version 2.1, to try to make to reduce the inter-observer differences, but still that is an issue lah. Okay, particularly not every radiologist in Malaysia is necessarily trained to do to assess PIRATS, so that's something you have to consider. Okay, and the other thing I have to consider is the availability of MRI, because you can't use open MRI. Ideally, you need a 3 Tesla MRI, for which I understand in government practice, it's less than 10 available in Malaysia, in the hospitals in Malaysia. And otherwise, you use 1.5, you need the endorectal coil. So the other problem is availability of the MRI. Okay, interpretation and availability. But I think this patient did manage to get an MRI, and this one shows a PIRATS 5 lesion that's confined to the prostate. Okay. So then after this, we decided to go for biopsy. Okay, so biopsy, how do we do biopsy? There are mainly two methods. One is transrectal, okay, and the other one is transperineal. Okay, this is what the transrectal looks like. So you have an ultrasound probe through the anus, and then the needle actually goes through the rectum and into the prostate, as opposed to transperineal, okay, where actually they still ultrasound probe through the anus, and then actually the needle doesn't go through the rectum, but through the perineal skin just underneath the scrotum. Okay, most hospitals for now in Malaysia still practice transrectal ultrasound guided biopsy, which I mentioned above, but the main concern has been, particularly in overseas, has been increasing infection, and particularly fluoroquinolone resistant bacterial infection post trans biopsy. So overseas, actually, you look at the guidelines, there is a shift towards a transperineal biopsy. But the problem in Malaysia is two. One is that it's more expensive. For example, in PPM, transperineal biopsy costs about 3,000 as opposed to 600 in transrectal ultrasound biopsy. Okay, and transperineal usually is done under GA, but now increasingly can be done under local anesthesia. In terms of cancer detection, so far studies have not shown a difference. The main thing is the infection risk, but in certain situations, such as a very anterior lesions, transperineal may be more favorable anatomically. Okay, so that's what I mentioned here. Okay, so biopsy is performed for this patient and come back as a Gleason 4+3. Okay, Gleason is the previous classification, but now we also have this new ISUP classification. Okay, so how do you stage prostate cancer? Okay, so stage for low, you can divide the patient into low risk, intermediate risk, and high risk. We come to that shortly. Okay, but usually for low risk, you don't have to do anything apart from the MRI, since MRI is done already before the biopsy. But for intermediate and high risk, you can do a CT, thoracic abdomen, and bone scan. Okay. Currently, if based on European guidelines, they don't really recommend as PET PSMA as primary. Okay, you can do it, but you have to understand that we're not so sure about the data regarding how it changes treatment decision making in the long term. But if you follow the US guideline, they actually they're more for PET PSMA for primary staging. Okay, so this patient actually went straight for PET PSMA and found no distant metastasis. Okay. Okay. So it's fine. Okay. So when you talk about non-metastatic prostate cancer, so these are some of the options that we can do. Okay. So active surveillance, radical prostatectomy, radiotherapy of two forms, EBRT or brachytherapy, and watchful waiting. ADT I put in brackets. Okay. So what's active surveillance? That means that you're actually aiming to delay active treatment. It's not that you're not giving it, but you want to delay so that you only do it when the symptom or when the patient actually progresses, i.e. the PSA go up or previously not palpable on DRE, but then you can feel it now, okay? And then once you feel that there is some progression or sometimes because of patient anxiety, then you switch to active treatment. So the aim of treatment is active, not palliative. Okay. Okay, of course, from urology, we have to talk about radical prostatectomy. Okay, so radical prostatectomy means you remove the whole prostate, okay, with the seminal vesicle and the vas, and you actually have to anastomose the bladder to the urethra. Okay, and usually we do it together, particularly in intermediate to high risk cases, we do it together with a lymph node dissection. Okay. Of course, the in thing nowadays is about robotic prostatectomy, but actually, a lot of studies, including meta-analysis, not particularly the latest by Cochrane, didn't find any oncological, urinary, or sexual advantage of doing a robotic prostatectomy. Okay, but normally we do it for patients with low to intermediate risk. Okay. Complications, the main thing we're concerned about will be erectile dysfunction, okay, which is almost all patients. Even if you do a nerve sparing prostatectomy, the risk is still there, and stress incontinence, okay. And other risks are common to surgery will be bleeding, bladder neck contracture, anastomotic leak, infection, DVT, urinary injury. These are things that are not common but can happen. Okay. Regarding the stress incontinence, actually most patients will be stress incontinent after surgery, but usually after physiotherapy and with time, usually by 1 year, most of them can remain dry. Okay. Watchful waiting is the opposite of active surveillance. I mean, you actually do not plan to give active treatment because this patient has low life expectancy or poor comorbidities, and the aim of treatment is actually palliative. Okay, so you're not going to after some time offer him prostatectomy or curative radical radiotherapy. Okay, we only will treat if symptoms develop with palliative intention. For example, if they cannot pee, you can do a TRP, or they have bleeding or pain, you can give a short treatment of radiotherapy. Okay. Androgen deprivation therapy, which is mainly a hormonal injection, to either luteinizing hormone agonist or luteinizing hormone releasing hormone antagonist. Okay, but usually we don't use it for those non-metastatic lah, but only in some patients where they have locally advanced prostate cancer who are unwilling or unable to receive local treatment after discussion, because ADT is not without complications, which I'll leave to Dr. Adila later to mention. Okay. Okay, so this is one I wanted to mention earlier. So once you have the diagnosis and stage of prostate cancer, so this is how you actually can re-stratify them into low, intermediate, or high risk. Okay, so this patient will come under intermediate risk. Okay, because the Gleason score is 7. Okay, although the C is T2, T2A, and the PSA actually C is T21 actually, because 1C because you couldn't feel it clinically, and the PSA is only 9, but because of the Gleason 7, so it comes with the intermediate risk. So question is, what should we do for this patient? Okay, so in terms of evidence, actually there's a recent paper just came out last month, show that in between the treatment options for non-metastatic patient, long-term didn't show any difference in terms of cancer-specific mortality. Okay, so just of interest, so we talk about the options. We know that this patient is of an intermediate risk. Intermediate risk means there's an intermediate risk of after curative treatment developing recurrence or metastasis. So for the people here, what would you recommend for this patient? Well, I think this one, there's no real right or wrong answer here. Okay. One thing about active surveillance, this is a ISUP 3 lah. So normally active surveillance you prefer for ISUP 1 or 2 lah. Okay, but of course you can discuss with the patient lah. Okay. So this patient, okay, actually, okay, one thing I wanted to mention. So you can actually go to this website, which is quite useful because you can actually give this link to the patient, and they can actually help you a bit, to talk to the patient about, what are the different options for early prostate cancer. So this is also thanks to the Family Medicine and the UCTF. Okay, so this patient actually decided to go for laparoscopic radical prostatectomy and had a lymph node dissection. A past lymph node dissection was just done last week. Thankfully, patient discharged well, and he's planned for cystogram before removal of catheter next week. Okay, so after that, we hope that he will recover well. Okay, so that's it for me.
So good afternoon, everyone. So my name is Nur Adila Mokhtar. I'm a clinical oncologist and a medical lecturer in UMMC. So I think Dr. Ahmad has already covered the screening, investigation, and the surgical aspects. And for my role, I'm going to share on how we treat the patient using a non-surgical aspect. So as an oncologist, normally patients' diagnosis has already been established by the time we come to us. So I think my 2 case presentation will cover one, localized prostate cancer, and the second one will be on the metastatic prostate cancer. And the reason for this is to share with you the journey of the patient after they have been diagnosed with prostate cancer and their treatment. And feel free to interrupt me or ask questions during my presentation. Okay, so you can move. So my first case presentation is about a 79-year-old man. He has several comorbidities, hypertension, aortic dissection, atrial fibrillation, chronic kidney disease, right heart failure, and he was on several heart medication, include amlodipine, apixaban, atorvastatin, bisoprolol, spironolactone, and furosemide. And next. When he first presented, he actually came to his GP. He went to his GP with mild lower urinary tract symptom, both obstructive and irritative symptom. And his GP prescribed alpha-zocin and finasteride at that time. And luckily, he thought about doing a PSA, and it was found to be elevated at 21. And he had a repeat PSA a few months later. It went down a little bit, but still a bit high at 11. But his urinary symptoms continue. He was then referred to UMMC for further investigation. Next. So what's next? So I think obviously he's going to have investigation like what Dr. Ahmad mentioned in his presentation. Next. So he had MRI pelvis, biopsy, CT cap, and a bone scan. Next. And his truss-guided biopsy confirmed there were it was confirmed adenocarcinoma from the both prostate with Gleason 4+4, which is high risk, and there was 80% tumor in the right lobe with 20% tumor on the left. Next. And this is his MRI scan, which shows there is a hypointense higher pointense uptake at the mid-gland, at the right lobe, and also at 1 o'clock at the left prostate lobe. Next. And this just to show you the several views of the MRI scan of his pelvis. And at the left bottom, that's the ADC window, which shows there is a hyper intense changes, which shows there is a tumor at the left gland, left prostate lobe, and there was no extracapsular extension. Then semivesical was normal. Next. And this is his bone scan, which showed no evidence of bony mets. Next. And his CT chest abdomen confirmed there was a newly diagnosed prostate carcinoma, no evidence of distant metastases. Next. And obviously it was confirmed that he has prostate cancer, a localized prostate cancer, high risk given that his Gleason score was 4+4. So he was offered the treatment options, surgery, androgen deprivation therapy, a radical radiotherapy, SBRT or external beam radiotherapy, and also brachytherapy. Next. So I'm just going to touch on the androgen deprivation therapy. So obviously this patient opted to have a radical radiotherapy. So we normally start the patient on ADT prior to starting the radiotherapy. And there are several options, which include the bicalutamide, which can be given as an oral, triptorelin, which is intramuscular injection, digaralex, subcutaneous injection, or Zoladex implant. So these are the options that can be given, and they can be given either monthly or 3 monthly. And the duration given depends on the risk stratification between 3 to 3 years. And for this gentleman, we offer him up to 2 to 3 years. So with deprivation therapy, there are side effects, which include tiredness, hot flushes, erectile dysfunction, weight gain, gynecomastia, thinning of body hair, loss of bone and muscle mass, mood swings, and increased risk of cardiovascular side effects. And for this reason, we normally advise the patient to have a lifestyle modification, because the weight gain, it can also cause hyperlipidemia, which can subsequently increase the risk of a cardiovascular like stroke, heart problem. Next. So he was counseled about radiotherapy, and just to emphasize to you, there are the pros about having radiotherapy. It is a non-invasive procedure. It can be tolerated quite well by most patients. It doesn't require anesthesia or sedation, but the downside of radiotherapy, it requires multiple visits. Patients need to comply with treatment schedule, and it can vary between 4 weeks to 7 weeks daily treatment. It requires a bladder and bowel preparation, and it can be quite costly as well. In UMMC, it can cost between 8K to 15K in total. And not all hospital in Malaysia has radiotherapy department. This can only be offered in government hospital. They are available in UMMC, IKN, and HKL. Next. And this is just to show you how the radiotherapy machine looks like. This is our linear accelerator radiotherapy machine, which we have in UMMC. So the patient will normally lie on the back on the couch, the black couch, and the machine, the gantry machine can rotate 360 degrees, depending on where we're treating. And next. And this is the process and how radiotherapy, how the process of the radiotherapy. Normally, the patient will get simulated. They will require simulation using the CT simulator on the top left, and then after that, they require planning. And the planning itself may take between 1 to 2 weeks. It requires a lot of calculation. And then after that, the patient will start the treatment. As you can see at the bottom picture, the patient has to be lie on his back, and the machine rotates around them. So the treatment duration can last between 4 to 7 weeks, depending on the intention. And for palliative treatment, it can varies between 1 fraction to 30 fractions. And each treatment normally takes about 5 to 10 minutes. It's painless. Patient doesn't normally see or feel anything during the but obviously there will be side effects, which I will talk about later. Next. So this is how we plan the radiotherapy. So as you can see, lots of colors. There will be, so we normally aim the target to the highest dose, which is the prostate, and then try to minimize the dose to the organ at risk. And this is just to show you how we plan it. Next. And the radiotherapy side effects, it can cause tightness, cystitis symptoms such as urinary frequency, urgency, diarrhea, skin reaction, sexual dysfunction or impotence, scarring of the bladder and rectal fistula. Next. So next. So this is the common questions about radiotherapy that we tend to get from the patients. Is it effective? And the answer is yes. Radiotherapy is effective treatment in curing the cancer. Does it cause any pain? No, it doesn't cause any pain, but it can cause side effects later on, which can start as soon as 2nd week onwards, and it can last weeks or months later. Radiation effects, what about family? Normally the radiation effect lasts during the treatment and it doesn't cause any radiation afterwards. The family, there is no limitation in terms of barrier with the family. Any immediate effect, normally the side effects occur as soon as 1 week after the treatment starts, and lasts a few weeks after the treatment finish. And is there any interaction or precaution with food? No, there is no interaction. However, we do advise patients to have some food modification, dietary modification during the treatment, as there will be some bowel preparation and bladder preparation prior to the radiotherapy. Okay, next. So regarding to the patient we've discussed earlier, so basically what happened, his PSA level started to drop after the treatment completed. And as you can see from September 2020 was 8, and then later on until the last PSA level in May this year, it was very low to the level of 0.09. Next. And he was continued to be followed up. The patient remained well. ADT was discontinued after 2 years, and he continued to be followed up with PSA checked every 6 months. So next. So this is just to share with you the oncology team in UMMC. We are friendly people, more than happy to answer any question or queries. So that's the end of my first case presentation. Okay, so earlier on, my first case presentation was on localized prostate cancer, and the intention was to cure the patient. And this, my second case presentation, is on a real case of one of my patients who was diagnosed with metastatic prostate cancer. So next slide, next. So this gentleman, he's a 60 years old, retired mechanical engineer. He lives with his wife. He has 3 grown-up children, non-smoker, non-drinker. He's known to have hypertension and diabetes, well controlled with metformin and antihypertensive medication. No family history with cancer. Next. He first presented with lower back pain for 6 weeks, and this worsened after long distance traveling. He had no lower urinary tract symptom. However, he did have some generalized weakness and poor appetite. He was seen by a GP and then referred to A&E in UMMC. Next. And then his initial investigation, he was found to be anemic, and then it continued to drop, and this included hemoglobin and platelets, and his iron was prolonged, and his anemia was found to be leukoerythroblastic picture. He also had abnormal liver function tests with raised alkaline phosphatase, ALT and AST. He was then referred to hematology for further investigation. In hematology clinic, he was noted to have multiple bruises over bilateral forearm, lower chest, and bilateral inner thigh. He continued to have severe back pain and lower limb weakness. Next. And then he had an MRI spine while he was inpatient. And as you can see, he's got multiple bony mets with vertebral compression, vertebral fracture compression. And there is, as you can see, there's an obvious on the right side, there is L4, L5 vertebral compression with no cord compression. Next. And this is just to share with you the MRI spine report, which shows diffuse vertebral body marrow changes with multi-level compression fracture. And it was suggested that this could be multiple myeloma. There was no evidence of spinal canal stenosis of nerve root impingement. Next. He was then had a chest X-ray, which was clear. He had a bone marrow aspiration and biopsy, which showed marrow infiltration by non-hematopoietic malignancy. And luckily, he had a PSA check at that time. It was found to be elevated at 128. Next. And this is just to show you his PET CT scan, which showed multiple bony mets throughout his spine and across his other skeletal. Next. So this is his PET CT scan report, which shows multiple abdominal lymphadenopathy, diffuse hypermetabolic sclerotic bony lesions. There was no visceral disease. Next. So at that time, his platelets continued to drop, and it was less than 20 with multiple bruises and gum bleeding. He required multiple platelet and blood transfusions. At that time, given due to his low platelets, stress-guided biopsy was not advisable. Next. So, so he was counseled for ADT upfront in view of unable to do stress-guided biopsy due to high risk of bleeding. Patient agreed and to start ADT without knowing the tissue biopsy result. Next. Luckily, we managed to request for trophon biopsy, and the result came back a few days after, which confirmed there was marrow infiltration by prostate carcinoma. The immunohistochemistry showed cytokeratin MNF 116 and PSA, which actually suggestive for prostate carcinoma. Next. So he was started on Degaralex, 240 milligrams, and abiraterone tablets, 1,000 milligrams daily with prednisolone. He was counseled for the potential side effects of abiraterone, which include tiredness, hypertension, abnormal LFTs, abnormal electrolytes, edema, and diarrhea. And next. So weeks afterwards, his platelets started to improve. And as you can see, it started to go up from 15 to above 100, normalized, and HB also improved. His LFT started to improve and normalize, and PSA started to drop from 128 to 4. And the patient's symptom improved gradually. He continued to have mild back pain, but not requiring regular analgesia. And next. So after then, denosumab injection was started after dental clearance. He was seen every 4 weeks for blood tests and blood pressure monitoring. His hemoglobin and LFTs remained stable, and PSA continued to drop to below 1, which the latest was 0.6. The patient remains well with no pain or any new symptoms, and the patient continued to travel and enjoy gardening during his free time. He was tolerating treatment well with blood pressure monitored by himself and GP. Next. So the take-home message for my case presentation. So prostate cancer can be presented with back or bone pain or lethargy, and it is advised or recommended to do PSA testing if it's suspected that if the patient is suspected to have prostate cancer. So metastatic prostate cancer can be treated and controlled for many, many years, and they can also have a good quality of life if the treatment is working. And there are many options available, which include hormone therapy, chemotherapy, targeted therapy, and radiotherapy. Okay, next. And this is just to introduce you to our UMM's Uro-Oncology team, which we tend to do on a weekly basis to discuss patient's case and management plan. And next. And that's all for my 2 case presentations. Any questions? Any questions are, you can ask any questions or queries. Thank you.
There's one in the chat box, I think.
Yeah, there's one in chat box.
So the question is, in this case, as patient presented with mild Lutz symptoms with his treatment, assuming he received radiotherapy, how can we assess patient's symptoms of Lutz? Is improved or persisted due to cancer itself or as a result of side effects of radiotherapy? Thank you, Arnold, for your question. That's a very good point. Normally, so before we start radiotherapy treatment, we normally have a baseline IPSS score where we know what his baseline urinary symptoms, and we normally counsel the patient that during radiotherapy when the radiotherapy starts, the symptom can worsen before it gets better. So I think I guess so how do we, so the question is about how do we know whether it has improved or persisted due to cancer itself or result of side effects of radiotherapy? So normally if with the radiotherapy treatment, as we know, it can worsen the symptom. So what we tend to do is we will offer the patient medication, such as tamsulosin, sulfasalazine, things like that, just to help to control the symptom. But we will not be able to tell which is which, whether it's due to the cancer or the radiotherapy. But as the treatment completed, normally the symptom will improve gradually, and we will check the PSA again. And that time we will be able to tell whether or not the treatment is due to the treatment or due to the cancer. So I think normally I think it's not an easy, it may not be straightforward to tell whether the symptom is actually related to the cancer or the radiotherapy treatment, but we always have a baseline IPSS score before we start the treatment, and for that we can actually compare with his baseline symptom. And as like I mentioned, normally the side effect, the symptom normally worsen during the treatment, but will gradually get better after treatment finish. And obviously, if it doesn't get any better, that's when we might need to do more investigation But normally, it will subside gradually, and we will recheck the PSA level. And normally by that time, the PSA will come down. And as we know, when the PSA comes down, normally we can tell that actually the treatment is working. So I guess there's not a it's not a straightforward answer, but that's how we assess the patient's symptom. And normally we compare it with the baseline symptoms before saying that this is related to treatment or from the cancer. Okay, hopefully that will answer your question. And no, thank you all for joining and listening. I hope it helps.
Thanks, everyone. I said this is the first time we are doing this Meet the Expert session. So do let us know in your feedback what you prefer, how do you prefer this to be run. Okay, we are open to suggestions.